Welcome back for another Sheriff of Sodium video. Today I'm going to give you a little primer on resident physician compensation and GME financing. What you're actually going to hear is a version of a talk that I got to give recently to a group of medical student leaders, but I think it's a topic that deserves discussion on its own merits because understanding how resident compensation was set at the level it was and how graduate medical education gets funded, all of this provides highly informative case studies about the levers of power and the importance of historical path dependence and the primacy of incentives and the inevitability of unintended consequences. You ready? All right then, let's go follow the money. Let's start here. Are resident physicians underpaid? Now, if you're currently a resident physician, or actually if you've ever been a resident physician, then this question may generate a certain knee-jerk response. Yes, absolutely yes. But I want you to pretend that you don't know anything about resident physicians, or the hours they work, or the value they add to patient care. I want you to analyze this question. I don't want you to make an emotional argument or a value-based argument. I want you to examine this question from a purely economic, market-based compensation standpoint. So from that standpoint, are resident physicians underpaid? To answer this question, it helps to have some real numbers. So here's one. For the current academic year, the median PGY1 resident salary was $65,100. Now, I want everybody to keep that in perspective. This figure is more than what 2/3 of American workers earn. You don't have to look too far to find people in our country who are working just as hard or harder than residents and earning less. But again, I said I don't want to make an emotional or value-based argument here. We, in matter of fact, have an economy in which different occupations receive different compensation based on supply and demand. Home health aides, housekeepers, the folks washing dishes or working on the line in the hospital cafeteria, they all have difficult and demanding jobs. But if those folks went to their boss and demanded to be paid more, the boss would just say no, because they know that even if that particular employee quits, they could hire a replacement for the exact same pay. So from that standpoint, are residents underpaid? I mean, if a program loses an intern, they typically don't have too much trouble finding someone to fill the vacancy, do they? And they don't have to increase the financial offer to do it. So if you can fire a resident making $65,000 a year and immediately hire another one at $65,000 a year, isn't that proof positive that $65,000 a year is the fair market compensation? Not necessarily, because you see what I did there? I used a very narrow definition of replacement. But remember, the work that residents do, it could be performed by others. It could be done by attending physicians, for instance, but you're going to have a hard time finding attendings to do it at $65,000 a year. And of course, that work could also be done by nurse practitioners or physician assistants. So how much is that going to cost you? Well, there was an interesting natural experiment that took place in 2019 at the University of New Mexico Medical Center. The neurosurgery residency program there lost its accreditation, but patients stubbornly continued to present with the same number of neurosurgical complaints that they ever had. So the medical center needed to hire nurse practitioners and physician assistants to do the work that had been covered by the residents. And how many of these nurse practitioners and physician assistants were required to replace the 8 departing neurosurgery residents? The answer is 23. In other words, it took nearly 3 APPs to replace each resident, but because those APPs earn more than a resident's salary, at the time the average nurse practitioner earned $115,000 per year in neurosurgery, it ended up costing the university 5 times as much to replace those residents with nurse practitioners and physician assistants. And before you tell me, oh, that's just in New Mexico, or that's just for neurosurgery, there are similar anecdotes for other specialties. In fact, if you look at papers in the literature, or better yet, if you hire a consultant to model the economic impact of adding a residency program to your hospital, the typical replacement ratio that's used is around 2 to 3 APPs per resident. When you consider resident replacement from an appropriately broad perspective, it should be clear that the fact that residents don't get paid anywhere near as much as their closest market substitute, it's strong evidence that this $65,000 figure represents structural underpayment and not a true measure of residents' economic value. And that leads naturally to another question, which is why? And that's what I want to answer this talk, but before I get there, I want to answer some different questions first. Here's one. How have resident salaries changed over time? The answer is they haven't, at least not for the past 50 years. The graphic I'm showing you here comes from the New England Journal of Medicine, and it shows resident salary over time, and look how flat that line is. Now, to make an apples-to-apples comparison, these authors inflation adjusted all the figures to $2012. And if I do that with the $65,000 figure that I told you a moment ago, it would convert to around $48,500 $2012. So, in other words, current resident salaries would fall just below the last couple of points on this scatter plot. Now, isn't that weird? I mean, it makes you wonder, how do we come up with the amount of money that residents would be paid, which is strangely standardized across all residency positions, regardless of specialty, and seemingly constant over time, imperviable from any market force that sets salaries in other industries. And somehow this value seems only to rise at the rate of inflation. How do we get this? Let me answer some other questions first. Why do residents earn so little? And here again, I want you to resist the temptation to be satisfied with the simple answer, which is because they're still in training. I mean, this is true and it is relevant, but it's superficial. There's nothing about this answer that sufficiently explains how we arrived at this particular figure. Remember, medicine is hardly the only job where a period of on-the-job training is required. I live in coastal Virginia, where shipbuilding remains one of the big industries. So if you want to be a machinist or a pipe fitter or an electrician who works building aircraft carriers or submarines, you need to complete a 4 to 8 year apprenticeship program. And when you start off, you'll make around half of what you're going to make when you're done, but you're going to get a progressive increase each year. You'll find something similar in many other industries. Airline pilots don't fly the big planes on day one. They start out as a co-pilot, and their salary grows as their skills and responsibilities increase. Same thing for highly trained military personnel, or even new hires at many tech and finance and consulting firms. But in those industries, what you see is that you get an initial salary that's a greater proportion of the final salary than what we have in medical training. And there are more rapid step-ups in salary that correspond to the acquisition of skills and the ability to add value. To be honest, though, things could be worse. I mean, look at dentists. If you want to specialize, you've got to complete graduate dental education. And if you're interested in a specialty that's not hospital-based, something like orthodontics or periodontics, you ain't going to get paid at all. Actually, you're going to pay tuition. And if you choose to do your graduate dental education at a private school, like the University in Pennsylvania, whose expenses I looked up just so I could give you some real numbers, the orthodontics program expenses are going to cost you $109,252 for the first year. And yeah, it's a 2 to 3 year program. My point here is there's nothing about receiving on-the-job training that necessitates compensation being set at any particular level. And other occupations have systems in place in which trainees receive anywhere from negative $109,000 up to the compensation that's actually a pretty reasonable proportion of what they're going to earn when they're done training. I think now it's time to answer that question that I posed a moment ago, which is, how did resident salaries get set? And the answer, like so many things in medicine, is historical path dependence. I think it's worth a few minutes of our time to review the history of this because it's foundational to understanding some of the forces and sources of tension in our current system. I should say, if this is a story you're interested in, I go into a bit more detail in the first part of my video series on the match, and I'll link to that in the notes below if you want to check it out. The key thing to remember is that for the majority of our country's history, residency training was not required to practice medicine. Until the 1900s, when you earned your medical degree, you were a doctor, and you were afforded all the privileges of such. As soon as you finished school, you could post up in the community and poultice wounds, or prescribe elixirs, or amputate gangrenous limbs, or do some bloodletting if that was your thing. Graduate medical education was entirely optional, and it was only pursued by the social and professional elite. And that's because, particularly in the early days of our country, there weren't really hospitals that had the capabilities of some of the hospitals in Europe. So if you really wanted to be on the cutting edge of medicine, You needed to go to Paris or Edinburgh or Vienna, pictured here, and learn from the masters. Of course, the masters don't pay you to learn from them. You travel on your own dime. So obtaining residency training was a privilege that only a small number of physicians could afford. However, when these physicians returned to the United States, their experience and credentials made them highly sought after as medical school faculty. And this resulted in a self-perpetuating system in which leadership in medical education and the upper echelons of medical profession and governments were limited to a small group of social elites, men of independent means who could afford to take a few years to live on their own expenses and train in residence in Europe. And that system obviously has had important reverberations throughout history that we continue to feel today. Things began to change in the United States by the mid to late 1800s. That change was driven by two factors. The first was the rise of the hospital. Between the Civil War and World War I, hospitals sprang up everywhere. Here's a graphic from JAMA in 1933 showing just how rapidly this occurred. But as patient care gets more complex, it became important to have doctors in the hospital 24 hours a day. In the telegraph era, it simply wasn't practical to summon a doctor from home in the middle of the night because a patient had a fever or needed an order for willow bark. The solution, of course, was resident physicians, and they were so called because, yes, they literally lived in the hospital. And modeling the experience that their forebears had in Europe, they weren't paid to do it. Resident physicians were compensated only with free room and board. This provided a natural constraint on hospitals' ability to recruit young resident physicians because while there were a growing number of young doctors who might have wanted the experience or the job opportunities that doing a residency might provide, it was tough for hospitals to find enough residents to fill their needs, given that the very real alternative to doing residency training was to simply not voluntarily live in the hospital and earn nothing and instead open a gainful, independent general medical practice. More than anything else, what helped the hospitals fill those residency positions was the rise of the specialty board. As medicine grew more specialized, doctors who had obtained residency training in a particular area needed a way to gatekeep and protect their economic interests. Protect the public from doctors who had not done residency training. So what they did is they created specialty boards, and those boards required passing an exam. But in order to be eligible for the exam, you had to complete a period of unpaid service, education at a hospital. And as you can see, by the end of the 1940s, medicine had been cordoned off into most of the specialties that we know today. So even doctors who wanted to practice in somewhat general areas like internal medicine still had to obtain residency training. The newfound incentive for all doctors to complete postgraduate medical education led to a period that the historian and physician Dr. Kenneth Ludmer describes as the democratization of residency. Among other things, for the first time, hospitals started to allow residents to live outside the hospital. From Ludmer's book, this resulted from the growing size of house staff programs. By the late 1940s, the number of house officers had become too large to allow them all to continue to reside inside the hospital. With great reluctance, hospitals began to provide living allowances to house staff in place of the long-provided room and board. The years following World War II were also the years when we had a dramatic increase in commercial health insurance in the United States, and this led to another critical change. Again, from Dr. Ludmer, interns and residents also reaped certain gains from private insurance. For the first time, they received salaries. This resulted from the policy of private insurers to reimburse hospitals for the costs of house staff coverage. At Massachusetts General Hospital, for instance, salaries in 1963 ranged from $3,000 for an intern to $6,000 for a fifth-year resident. That's a little over $30,000 and $60,000 in today's dollars, by the way. However, in 1950, interns there had received only room and board, and fifth-year residents a stipend of $1,200 plus room and board. So now we have a system in which residency is turning more into a normal job where you don't have to actually live in the hospital and you actually get paid a salary. And that salary is being paid by insurance companies. And this is the system that laid the groundwork for one of the most important events in the whole history of graduate medical education. That, of course, was the passage of the Social Security Act amendments in 1965, which established Medicare and Medicaid. This created governmental health insurance programs for certain groups of people, and given that private insurance companies had set the precedent of paying residents for the care they provide so they didn't actually have to live in the hospital, it seemed only right that Medicare and Medicaid would do this too. And so it came to pass that CMS committed to covering some of the costs of resident education. Now, as an interesting historical aside, I want to point out that Congress intended that their financial support for residents would be temporary. Here's an excerpt from the House and Senate reports on the bill, which note that it is intended, until the community undertakes to bear such educational costs some other way, that part of the net cost of such educational activities, including stipends for trainees as well as compensation for teachers and other costs, should be borne to an appropriate extent by the hospital insurance program. Now, obviously, this hasn't occurred. Private insurers have long since stopped adding surcharges for resident care, and at a certain point, hospitals were happy to have them do it because making hospital bills higher for patients with private insurance if they went to a teaching hospital would have put them at a competitive disadvantage. On the other hand, these days, federal funding for DGME has become a massive entitlement program that hospitals and their constituencies guard jealously and aggressively. And how CMS funds residency training remains at the center of many of our modern policy debates. I'm going to get into the nuts and bolts of how Medicare funds residency training, but before I do, I need to clear up a couple of little linguistic issues. First, do residents receive a salary or a stipend? The answer depends on who you ask. If you ask the AAMC, or your GME dean, or your department chair, you're likely to hear resident compensation described as a stipend. The term is historically accurate, and some people may just use it out of habit or nostalgia for the good old days. But if you find someone that insists on using this term, or better yet, corrects you if you say salary, it's a tell that you're dealing with a hardline establishment guy. Because when they use it in that context, the word is intended to connote that the money that residents receive is just like it was in the old days. It's just enough to cover what the hospital would have given you if you'd wanted to live there and eat the hospital food for 3 to 7 years. It's money that's only intended to support some minimal standard of living. And of course, such a figure could only rise at the rate of inflation. It's not an amount that's subject to negotiation or would change with market forces or really anything else. But you'll notice that unless I'm citing the historical record, I use the term salary because that's literally what it is. It's a fixed, regular payment from an employer to an employee for work performed. Now you'll notice I just said the word employee, and that brings me to the next little technical issue that we need to get straightened out. Are residents employees or just students and learners? And obviously the right answer should be both. I strongly believe that faculty have a professional obligation to teach residents. It's exploitative to treat residents just as a source of cheap physician labor. But I would also put it to you that the residents are just students line of argument is also exploitative insofar as it ignores the economic realities that I just discussed, and it contributes to this assumption that residents are supposed to be penurious. And actually, the question of whether residents should be regarded primarily as employees or primarily as students and learners isn't just a matter of semantics or opinion. It's actually settled case law. The case is Mayo Foundation versus United States. The Mayo here refers to the Mayo Clinic, which of course employs a large number of resident physicians. Now, by law, employers are required to withhold a certain amount of money from each paycheck to cover Social Security and Medicare taxes. And actually, the employer has to match that amount. But because Mayo regarded their residents as students who were receiving a stipend and not as employees who were earning a salary, they asserted that they should not have to pay those taxes, which the IRS had started asking hospitals to do in 2004. When the case was filed, the AAMC and the American Hospital Association and others filed amicus briefs arguing that residents were primarily learners, not workers. Well, the Supreme Court disagreed. In a unanimous decision, the court found that residents are workers who study, not students who work. All right, let me move on to one of the most frequent questions that I receive, which is this. how much does Medicare pay each resident? And the answer is 0. Medicare pays residents nothing. Medicare only pays hospitals. And if it seems like that's a minor point, it's not. It's a point that becomes particularly relevant when a program loses its accreditation or when an entire hospital shuts down. One illustrative example came in 2019 when the Hahnemann University Hospital in Philadelphia suddenly declared bankruptcy. At the time, Hahnemann had around 550 residents and fellows, and all of a sudden they needed new homes. And this would have been chaotic under the best of circumstances, but among other things, programs that were interested in taking some of the Hahnemann refugees were uncertain about whether they'd be able to receive the Medicare funding that the old training program had been receiving. That funding doesn't automatically follow the resident. It's a hospital asset, and the hospital gets to decide what to do with it. And here's what Hahnemann wanted to do with it. They wanted to sell their positions at auction to a group of 6 other hospitals for a price of $55 million, which amounted to around $100,000 per position. And this sale would have closed had CMS not objected and tied up the issue in court. Still, the point remains that the money to train residents belongs to the hospital. And even if the hospital no longer has any residents to train, it's nonetheless the hospital's voluntary decision to transfer their funded positions elsewhere or not, as is clearly laid out in the Code of Federal Regulations. So let's refine that question just a little bit. How much does Medicare pay hospitals for each resident? And the answer here is, it depends. And it gets a little complicated. But if you stay with me, I'll show you the basic inputs. There are 2 main payments that Medicare makes to hospitals for training residents. Those are direct medical education payments, or DGME, and indirect medical education payments, or IME. Let's start with DGME. This is the subsidy that I told you about a few minutes ago that Congress enacted in 1965. It's called DGME because these payments were intended to support the direct costs of training residents. Those are things like the resident's salary and the salary of their teachers and other costs. But notice that Congress never committed to covering all the direct costs, only that those costs would be borne to an appropriate extent by the hospital insurance program, which is Medicare. In other words, Congress only ever agreed to cover the training costs for residents that were taking care of Medicare patients, which, as you remember, was similar to what private insurers were doing at the time. So the first thing to understand is there isn't a single fixed DGME payment that hospitals receive to train residents. The amount is prorated based on the number of Medicare patients that the hospital cares for. Here's the basic formula. There's a per resident amount, or PRA, and you multiply that by the number of full-time equivalent residents in the program. And then you discount it based on the Medicare patient load. Now, there are some additional complexities here related to how that per resident amount gets set and how the number of FTE residents are determined, but for now, I want to make sure that you're seeing the big picture. And the big picture of how much money we're talking about looks like this. In fiscal year 2020, Medicare spent $4.5 billion on DGME payments, which covered a total of 88,247 trainee FTEs. So as a crude average, that works out to $50,993 per resident FTE. Here's how that works out for hospitals. As you can see, the top recipients of DGME payments receive over $100 million a year for DGME. But I told you there were 2 major residency funding streams, so let me tell you about the other. IME, or indirect medical education payments, started in the 1980s, along with a fundamental overhaul of the way that Medicare paid hospitals. Believe it or not, up until then, Medicare just paid whatever bills hospitals sent them. However many days a Medicare beneficiary stayed, whatever medications they took or diagnostics they received, Medicare just cut the hospital a check. Unsurprisingly, this led to skyrocketing costs, which were incompatible with President Reagan's policy agenda, which required federal spending cuts in order to fund tax breaks. So in 1983, Congress passed an amendment to the Social Security Act, which started the prospective payment system for Medicare. And this, more or less, is the system that's still in place today, in which hospitals receive a single fixed payment for a patient's entire hospital stay based on their DRG code. So instead of rewarding hospitals for keeping patients longer or doing more stuff, the PPS incentivizes hospitals to provide leaner care. If you get the hospital patient discharged quicker or use fewer services when you care for them, well then the hospital gets to keep more money from that fixed DRG payment instead of having it disappear in their overhead. But this created a problem for teaching hospitals who were worried that resident-based care isn't always efficient. I mean, residents might order unnecessary tests. Plus, the patients who go to teaching hospitals, they tend to be more complex cases and have more adverse social determinants of health. So the teaching hospitals asserted that they ought to be paid more so that they could compete with the community hospitals in the new DRG-based world of Medicare PPS. Congress agreed, and so it came to pass that IME payments were created. Rather than being a fixed amount, the IME payment is a percentage that gets added on to the amount that Medicare would have paid for the patient's care. So, if a hospital admitted a Medicare beneficiary for, let's say, pneumonia, and would have received a $5,000 DRG payment, if they had an IME multiplier of 10%, the hospital would actually get $5,500 from Medicare for taking care of that patient's hospitalization. The formula for calculating IME payments looks like this. As you can see, most of the inputs here are set by the government. The only variable hospitals can really control is their ratio of interns and residents to beds, or IRB. But importantly, whatever the DRG add-on is, the hospital receives it for all Medicare patients, regardless of whether residents actually participated in that patient's care or not. So how much money are we talking about with IME? Again, there's wide variation from hospital to hospital, but let me give you some big picture numbers. In 2020, Medicare paid around $11.68 billion for 98,542 resident FTEs. So if you do the math, that works out to $118,528 for every resident on average. And here are the top 10 hospital recipients of IME payments in the year 2023. As you can see, we're talking about a lot of money here, with the top hospitals receiving well into the 8 to 9 figures for IME payments. But let me get back to the original question, which was, how much does Medicare pay hospitals to train residents? And if we add up the average DGME payment and the average IME payment from 2020, remembering, as I said, that these are just crude averages that vary significantly from hospital to hospital, so many hospitals will certainly make less, but there'll be some who make more, we would get a grand total of $169,521 per resident FTE in the year 2020. $169,521. So if you're keeping score at home, that's somewhere around 2.5 times the average resident salary. And these figures, again, beg the question, why don't residents get paid more? And I'm going to answer that question, just not yet. Because first I want to clarify some other technical issues that you need to understand when you're talking about these figures so that you don't put your foot in your mouth. First, not all hospitals care for Medicare beneficiaries. Medicare, as you all know, provides primarily coverage to adults 65 years and older, with a couple of special cases for patients who have end-stage kidney disease or ALS. So children's hospitals, for instance, they may not have any Medicare patients aside from a handful of kids on dialysis, so they would receive essentially no Medicare residency funding. Now, there is a separate federal program called Children's Hospital DGME that provides funding to freestanding children's hospitals to train pediatric residents. It's a little less generous than Medicare. In 2021, CHGME paid $74,221 per resident, which is a little less than half of what Medicare paid between their DGME and IME payments. There are other examples, too, where differences in case mix limit the amount of Medicare patients and Medicare funding that the hospital receives. For instance, imagine that instead of a community hospital with lots of elderly patients with medical and surgical issues, imagine that your hospital's big unit is a labor and delivery ward. Well, stands to reason you're not going to find too many patients over 65 over there. Or imagine that you have a hospital with a trauma center in an area that has a lot of gun violence. Or a hospital that serves a large number of non-U.S. citizen immigrants. those patients aren't going to qualify for Medicare. However, all these patients may qualify for Medicaid, and actually, to complicate things further, 90% of state Medicaid programs also provide some GME funding, although there are some states like Massachusetts and California that do not. But some state Medicaid programs are extremely generous, and head and shoulders above all the rest is New York. In 2012, New York accounted for nearly half of Medicaid GME support for all states, providing $1.8 billion in GME funding, which worked out to an additional $115,500 per resident. Second point, there's a cap on DGME payments. Notice my last two words there. There's this popular misconception that Congress has capped the number of residency positions available. This is, I think, often an intentional misunderstanding by people who want you to believe that we have a physician shortage, but I digress. I've talked about the history and implications of this elsewhere, so I'm going to try to be brief, but this is all a result of health policy actions that took place in the 1990s. Back then, there was real worry that we were training too many doctors. This was the managed care era, and HMOs at the time felt that they needed only 100 to 150 physicians per 100,000 population. But at the time, we had nearly twice as many doctors, with numbers that were expected to grow in the decades to come. There was even an expert panel that went so far as recommending closing some U.S. medical schools to reduce enrollments by 20 to 25%. Now this, understandably, was a policy to which the AAMC took strong exception. In testimony to Congress, the AAMC correctly pointed out that closing U.S. medical schools wouldn't even fix the doctor surplus because as long as Congress was giving away free money to any program that wanted to train residents, hospitals would continue to grow their residency programs just using graduates from overseas. A better solution, according to the AAMC, would be policies that would reduce the number of first-year residency positions. So that's what Congress did. As part of the Balanced Budget Act of 1997, Congress capped the amount that Medicare would pay in DGME to the number of residents that were training in the year 1996. The DGME cap did pause, at least temporarily, the growth in new residency positions. Look how that line goes flat for a few years there. But by 2003, the number of residency positions began to grow again, and the slope of that line is similar to what it was in the 70s and 80s. And it's obvious why that happened. I mean, like you know, DGME is only a fraction of all residency funding. These days, IME payments are around twice what DGME payments are, and honestly, most hospitals don't need either one in order for having residents to be a better than break-even business proposition. Last point. The counting of residents to plug into these formulas, it isn't completely straightforward. When you're talking about DGME, not all residents count as one resident FTE. Medicare will only support resident training for a limited period of time. That period is called the IRP, or Initial Residency Period, and it corresponds to the number of years of training that it requires to become board eligible in that specialty. The IRP gets set the day you begin residency and doesn't change thereafter. So if you match in internal medicine, it's 3 years. OBGYN, 4 years. Surgery, 5 years. During that period, you get to count as one FTE toward the DGME cap. So let's say you match in internal medicine, but you decide afterward you want to do cardiology or GI. Well, after 3 years, you're board eligible in your primary specialty, so for your fellowship, you can't count as one FTE, you only get to count as 0.5 FTE toward the DGME funding cap. Or, let's suppose you match in internal medicine, but then you decide you want to do radiology. I mean, you can switch to a radiology program if you can find one willing to take you, but once you finish your third year of residency, the hospital will only be able to count you as 0.5 FTE toward their cap. Obviously, this creates a financial disincentive for programs to take certain transfers. And all this gets even trickier if we're talking about applicants who don't match into categorical specialties and SOAP into prelim year positions. Because if you start your training as a prelim, PGY1 only medicine resident, you're still a medicine resident, so you're only going to get 3 years of full DGME funding. So if your heart's desire is actually to become, an anesthesiologist or a dermatologist or a radiologist or an orthopedic surgeon, you may have been better off doing a surgery prelim year, at least insofar as you'd have an IRP of 5 years, and you would then be a better business proposition for programs that might be interested in taking you after the prelim year is over. Let's move on to the next question. Should federal DGME payments be reformed? This is an easy one, and it's a 3-letter answer. I hope it's clear from reviewing this history that the system we have is the end result of 70 years of cobbled together political compromises and adjustments and workarounds. It's a system that does not approximate in any way the kind of system that you'd create if you were designing one from scratch today. I mean, capping DGME payments, it makes some sense insofar as we don't want a system that incentivizes the creation of residency positions that we don't need. But what this did is fix in time the distribution of residency positions that we had when Biggie and Tupac were still alive, which is one reason why we have an abundance of residency programs in the Northeast and across the Rust Belt, even as the American population has shifted south and west. The idea of IME payments, that makes some sense, but careful study has shown that the actual amount that residents increase expense is around 2%, which is a fraction of the average IME add-on. In practical terms, IME payments go to subsidize indigent care, which could be more fairly and sensibly done in other ways. And of course, this whole system is ridiculously expensive. So what do we, as a society, get out of it for this degree of investment? It's a system that doesn't allow for thoughtful workforce development. It leaves it up to individual hospitals to decide whether and how many residents to train. It's a system that rewards inpatient care, even as more medicine is occurring in the outpatient setting. It's a system that stifles innovation, and it provides no financial incentive to hospitals to make resident training more efficient or higher quality. Instead, it contributes to making training pathways longer and longer. Instead of something transparent and flexible, we have a complex and calcified entitlement system with formulas that have been added onto and tinkered with so many times that they have little relevance to the actual thing they were supposed to be adjusting for originally. And it's given rise to a legion of highly paid consultants that would love to have your GME naive hospital as a client, so they'll come in and crunch the numbers and tell you how to set up things so that you can make the maximum amount of money by training residents. And obviously, it's a system in which it's easy for residents to be transformed from skilled professionals into pawns and worker bees and bargaining chips to be used by powerful business entities. Honestly, if you left it up to me, I'd stop giving the money to hospitals, period. And instead, I'd give it to the residents. I'd create a planning authority that would carefully consider how many neurologists and urologists and pediatricians we think society needs and issue vouchers for a certain number of residents to train those specialties. You train that specialty, and at the end of the year, the hospital that trained you, they can cash in that voucher for money from CMS. But if you mistreat your residents and they leave the program, well, the program that takes them gets to cash that voucher. Imagine how a system like that would change power and incentives and societal return on investment. But I'm getting off the track here, so let me move on to the next question. This is one I feel compelled to answer because it comes up so frequently. Do hospitals lose money training residents? Again, this is an easy one, and it's a 2-letter answer. But I want to answer it a little bit more rigorously because the question of whether it costs more to train a resident or replace them has been rigorously analyzed. The most comprehensive and even-handed analysis was done by the Rand Corporation back in 2013, and after accounting for all the relevant financial inputs and outputs, they concluded that adding another internal medicine resident could have an impact ranging from a $101,000 loss to a $250,000 gain. Adding a cardiology fellow ranged from a negative $107,000 loss to positive $340,000. So yes, it's possible that you could add a residency position, and if that position doesn't enable any additional patient billing beyond what was happening before, or create any additional government subsidy, well then yes, in such circumstances, adding another resident could be a financial loser. But it strains credulity to think that this would occur on any scale. Because if it were really true that hospitals were losing money on residents, don't you think some smart guy in the C-suite would have figured that out already? I mean, why wouldn't the hospital just get rid of the residency program altogether? But actually, that's something you hardly ever see occur. I mean, sometimes you see residency programs close for accreditation issues, or maybe even the whole hospital goes under. But you just don't often see a hospital close up a residency program because they think they're going to do better financially without it. Instead, you see the very opposite. New hospitals are opening GME programs every year. In fact, these days, the single biggest sponsor of GME in the whole US of A is HCA, which is a for-profit corporation whose mission is to return value to their shareholders. In reality, if a person tells you this, they're using selective accounting. They're adding up all the residents' salaries and benefits and the structural costs of the institution, and then against that, they're saying the CMS subsidy doesn't cover it. And they're ignoring all the ways that residents add to the bottom line elsewhere because the billing that they generate and the other things, they show up on different balance sheets. This is a technique I like to call budgetary gerrymandering, and if you want to know more about it, I've actually got a separate video on that topic. But right now, let me answer one last frequent question before getting back to the fundamental question that I dodged earlier. Does the match suppress resident salaries? There are many who claim that it does. The argument goes something like this. If there were no match, then residency applicants could apply to jobs and negotiate contracts just like in any other industry. And in such a free market, highly competitive residency applicants might be able to hold multiple job offers at the same time and play employers off each other to get higher salaries. Oh, well, Stanford has already offered me such and such, so if you want me to go to UCSF, I'm afraid you must improve your offer. I gotta tell you, I think this is a pipe dream. The thing you gotta remember about residency selection is that there are more applicants than positions. And that's true at every strata of residency selection, whether you're talking about ultra-competitive academic orthopedic surgery programs or community family medicine programs that exclusively recruit IMGs. You've got more applicants for a type of thing than there are of that thing. And the first person out is probably indistinguishable from the last person who got in. So how likely do you think it is that programs are going to get into a frenzied bidding war to sign an applicant that got 5 points higher on USMLE Step 2 CK just to keep them from going to their competitor? I don't see it. I think what's incredibly more likely is that qualified applicants who get left out of the current system will drive prices down. I mean, if you're an unmatched dermatology applicant, would you accept 90% of the current salary if it meant you got a position? I bet you would. What about 80%? 50%? Honestly, there are probably some applicants out there who would be willing to pledge themselves to a residency program for free. And don't start with the stuff about how residency programs only want the best applicants. They want the best applicants in a system in which all applicants cost the same amount. If you allow the cost to vary, that calculus changes. 90% of the quality at 50% of the price, that's a bargain, brother. I don't think that blowing up the match would improve resident salaries. The central truth of the matter is that there are more residency applicants than positions, and when supply exceeds demand, prices don't rise. They fall. And if you aren't satisfied with my logical but theoretical rebuttal, then I want you to know there's some empirical analysis of this as well. This is a paper by an economics professor who analyzed data from the family medicine match to estimate the implicit tuition that residents pay when they choose to go to a more prestigious or a higher quality program or a program in a certain geographic area. He used that to conclude that even if there were no match, resident salaries would remain $23,000 below the value of their labor, and that was in 2010 dollars, so it'd be around $33,000 today. So let me get back to the question that I've been trying to answer this whole time. Why don't residents get paid more? I mean, should we pay residents more? Given that, as we've seen, the cost of replacing resident labor with the next closest market alternative costs multiple times as much. And that's not even including the availability of generous governmental subsidies. You don't get them things for NPs and PAs, and those subsidies can run into the hundreds of thousands of dollars. Well, let me turn that question on its head. Because really, why would a hospital pay any more than they already do? What would happen if they didn't? The answer is, financially speaking, absolutely nothing. Remember, we live in a world in which there's 1.3 residency applicants for every residency position. Any residency position that a hospital creates will get filled. Now, might it fill in the SOAP instead of the match, or by an applicant with a lower USMLE score, or by an international medical graduate instead of a US graduate? Sure. And it's true, program directors care about appearances, and those things are relevant. But I said at the beginning I wanted you to make a financial case here, and that's what I'm doing. If a hospital refused to raise resident salaries, absolutely nothing would happen to them financially. They'll fill their positions, and they'll get their subsidies, and that's that. There are important structural factors that prevent residents from achieving their market value. And the most important of those factors is this. Residents can't really vote with their feet. In all states, you have to complete at least 1 year of postgraduate medical education to receive a medical license. But even then, the kind of jobs that are going to be open to you are not the ones that you dreamed of when you decided to go to medical school. If you want to be a real doctor who works at a hospital or contracts with insurance, you have to be board eligible. And that means you have to finish a residency. There's just not much market value for a half-trained resident. I don't think this is an overcomable problem. State licensure laws and board certification requirements, they're not going to go away. And I guess I should be clear that I'm not arguing that they should. But what I mean is, I don't think that resident physicians are likely to earn their true market value, at least not anytime soon. But that doesn't mean that resident salaries can't be improved. So let me answer just one last question. Should residents unionize? This is actually a topic I've discussed before, and if you missed that, I'll link to my video on Resident Unionization Part 1, Lessons from Hamburger University, in the notes below. Back in the day, I promised you that Part 2 would be forthcoming, and I still mean that, because analyzing the trade-offs to resident unionization, it deserves a little bit more of a thorough handling than I can give it in this video. So for now, I'm going to leave you with just one brief anecdote. It comes from the very public fight to unionize the Mass Gen Brigham residents a couple of years ago. The story here is from the Harvard Crimson, and it describes how, after the residents started taking steps toward creating a union, funny things started happening. All of a sudden they got an email saying every resident got a $3,500 cash bonus. And then, just 3 months later, they got a 10% salary increase and an increase in the cost of their living stipend, which is actually something separate from their salary, up to $10,000 a year. And they got some expanded benefits. And they got all this before they even had a union. So riddle me this, Batman. Why would the hospital do that? Why would they suddenly throw all this money at residents unless they thought they'd have to spend more if the union got formed? There are significant structural factors that prevent residents from being able to achieve compensation that matches their true economic value. And those factors ain't changing anytime soon. There are trade-offs to consider, but short of major reforms elsewhere, collective action is probably the likeliest way that residents could coax more of their actual economic value into their own paychecks. And for now, that's all I've got. Thanks again for listening.